Well, we are moving into some more sort of specific sections now. And it is really a great pleasure to introduce you to two people who represent our most cherished partners in the world. Crick, Lund, who somehow we've managed to attract him to London with a percentage of the time, but he is based at Cape Town, University of Cape Town in South Africa. And Charlotte Hanlon, one of our best exports to Africa, who has done a marvelous work in Ethiopia. Would you like to come on stage?
Great. Good morning, everybody. So this one's a team effort. I'm going to kick off, and then I'll hand over to my sidekick, Professor Crick. And we're going to take you on a bit of a whistle-stop tour. So looking back and looking forward, but focusing particularly on integration of mental health within primary care. And as Ricardo said, both of us are employed by King's College London, but we're both located in Africa. Now, first of all, let's start with prehistory of the centre, of what's been going on in the area of integration in mental health in primary care. So if we unroll these papyrus scrolls from the archives of the WHO, these are reports dating from the 1980s, and the quote on the right-hand side is from the 1970s. And this is, the WHO has been engaged in advocating for integration of mental health in primary care for decades now. And you can see that the main thrust of the argument about what needs to be done hasn't changed very much. So in the quote, it's about expanding mental health care to different healthcare workers, particularly primary care, and a focus on priority conditions. One thing that's changed is it's not only psychiatrists who are doing all of the asserting now, so that's one of the good changes. This is a nice review that was done by Alex Cohen and published in 2001, looking at, well, these efforts had happened by the WHO to expand mental health care in primary care. But what did we know from the research evidence? What was telling us, what information do we have to improve upon these models of care and know whether they were truly effective? And it was a little bit of a dismal kind of conclusion that most studies were very descriptive. They were focused on thinking about, had knowledge changed pre and post training of mental health workers in a primary care setting, nothing on competence, no control groups usually, and very much an assumption that if you trained people, that would automatically translate into sufficient quality of care that you would be able to actually improve patient outcomes. And almost no consideration of the implementation outcomes or describing those in a systematic way. Now in this slide, this sort of takes you now, we're into the last decade, and some of the kind of really key moments that have framed what we've been doing in the area of mental health integration in primary care. So in 2008, we have these seminal publications from WHO and Wonka, integrating mental health in primary care. And that was mostly based, there's a lot of very useful and important case studies and descriptions in that document, but not much kind of rigorous research evidence. And then, of course, the World Health Organization's Mental Health Gap Action Program. You can see the two intervention guides, 2010, and then revised and updated in 2016. Those are the clinical guidelines for frontline primary care workers and general health workers in low and middle income countries based on extremely rigorous reviews of evidence and made applicable for low and middle income countries by restricting to essential medicines lists and practical and plausible solutions. And then some other kind of really important steps, really, I think, that have marked out this decade compared to the previous decade. The operations manual from the WHO starts to engage with the nitty-gritty of implementation and thinking about how different contexts affect the way that mental health is integrated. and how health systems form an incredibly important role in framing what needs to be done. And then hot off the press, just published a couple of weeks ago, is the community toolkit to go alongside MHGAP, which really recognises that when we're talking about primary care, as in the Alma Ata Declaration and updated in Astana, the community is a fundamental component of what we can conceptualise when we're talking about primary care. And then if we think about what's been achieved in terms of expanding MHGAP and this approach to integrating mental health in primary care, in the 1970s and 1980s, it was just 1 or 2 countries per continent and quite small scale, and mostly related to research projects or small-scale projects. And now you can see that there's activity in more than 100 countries in all of the WHO regions. So that's the scale of what's being done has transformed as well. What about the research evidence? Well, now, this is not completely exhaustive, so forgive me. You're more likely to have got on this slide if you have a nice logo. So what kind of research do we have? So here, these are some of the really big multi-country research program consortia that have been focused on implementation research and have really been looking at kind of entire service models with integration across different mental health conditions. And we're going to pull out some of the evidence. Crick's going to tell you some of the things that we've been finding from these big studies. We've had RCTs. Ricardo mentioned about the NIH Hubs program, so very high quality evidence, and the studies ringed here are focusing on people with severe mental disorders with interventions in primary care and in the community. Then we have models of depression care, stepped care models including psychological interventions, but also referral pathways and medications. And then the biggest activity has really been in evaluating psychological interventions for specific conditions, and this is for depression and anxiety in this group, that can be delivered by primary care workers or community health workers in some form of task sharing. And this group of psychological interventions ringed here is perinatal mental health, where there's been a lot of focus as well. And then a couple of studies that have been looking at different aspects of integration of mental health in primary care. So in Reshape, it's about reducing stigma through involvement of service users in the training programs for primary care workers. And with Amelia, it's about how mental health care, the MHGAP is the decision support tool is delivered to the providers through electronic means. So in the last 10 years, I think really important development that has really distinguished what's been happening is also a much better grappling with the complexity of what it means to integrate mental health in primary care and more focus on implementation. This inevitably takes us to talk a little bit about PRIME, the Programme for Improving Mental Health Care, a DFID-funded programme which was over an 8-year period. And remember the intervention guide that I mentioned from the MHGAP? You can see it's a very small part of this matrix. And this matrix tells you at different levels of the health system, from the community at the bottom row, the primary care facilities, specialist mental health care, and then health systems and organisations, what you've got are different packages of care that are required to support that little bit of integrating mental health in primary care. So this is completely different from the idea of sort of hit-and-run training of primary care healthcare providers just with short mental health training. That's not how integration of mental health in primary care is working. Another defining and important feature of programs like PRIME, not exclusive to PRIME, has been using theory and really trying to use the MRC complex intervention framework. And clearly it's a very complex intervention. And so approaches like theory of change are a very useful way of thinking about this. Theory of change, we start with what we want to achieve, so improved clinical, social, functional outcomes for people with lived experience of mental health conditions, and then you go backwards and you kind of map out with stakeholders in a participatory way, I think, which is perhaps another development over the last 10 years, more participatory planning. And you work out what's needed and the intermediate steps, what are your assumptions, and how will you know success when you see it? And how will you know failure when you see it? And this has been extremely useful for interrogating, what's working, what's not working, what could be optimized further, and how could we channel our resources so they're most optimally used. And then the third component of PRIME, just to highlight, was been really the way that evaluation was done and what it was trying to answer. So if we think about what a health system is meant to deliver, it's meant to be delivering improved population-level health through improved coverage of appropriate and evidence-based services that are equitable. And those were the key outcomes of PRIME. And we used different sets of methods, including community surveys and facility detection surveys. We had individual patient outcomes as well to see whether the care really did translate into an impact for individuals, and then a case study to really understand the nuts and bolts of what was happening. So now I'm going to hand over to Crick, who's going to take you through, well, with all that activity going on, where has that left us now in terms of what we know that we didn't know perhaps 10 years ago?
Well, good morning, everybody, and it's really a great pleasure to be here. Happy birthday to CGMH. It's really wonderful to be here and to be part of the celebration. So I'm going to crack right on and continue with Charlotte's line of thinking. I want to start by reporting back a little bit about what we found with PRIME, focusing on some of these key outcomes. So just to recap, as Charlotte mentioned, we set out to improve mental health among people who received services through integrated primary care facilities and community settings, to increase coverage, that is the proportion of people living with a mental health condition who are actually receiving evidence-based care, and to do so in an equitable way, which didn't disadvantage people by virtue of gender or socioeconomic status. And the good news in terms of improving mental health was that we found a fairly consistent pattern across the 5 countries of improved mental health functioning and social outcomes among people who received care. So this is really an important development in the field. It shows that we can actually deliver care using non-specialist providers in very low resource, very constrained environments, primary care settings, to deliver care that leads to improvements in these mental health outcomes. When it comes to coverage, we saw an increase in service utilization across the countries when we tracked through our case studies the number of people who were actually attending primary care facilities, so that was encouraging. But we saw varied impact on population-level coverage for depression and alcohol use disorders. This is partly a measurement function. It was really a challenging undertaking to do repeat population-level community surveys to show an impact at the population level on coverage. But I think it was also a real challenge in increasing coverage to conditions that are often difficult to detect in primary care settings. However, with active case finding, we were able to show significant improvements in coverage for severe conditions like psychosis and epilepsy, especially in Ethiopia and Nepal. And then we found varied impact on the detection, the capacity of primary care workers to detect depression and alcohol use disorders. In some countries like Nepal and South Africa, it increased significantly. In Uganda, it increased at the first follow-up time point, but then went back almost to baseline at the final end point. And in Ethiopia and India, we didn't see an improvement in detection of depression and alcohol use disorders by primary care providers. What was particularly encouraging when we looked at the cohorts and the nested trials which we ran in PRIME is that we didn't see inequitable impacts. In other words, there was no difference by gender, residence, and socioeconomic status in these mental health improvements that we saw, which is very encouraging. So the strategy of integrating mental health into primary care improves access and can lead to improved quality of life and reductions in mental health symptoms for people who receive care in those settings. However, if we were to think about where do we go next, some of our key takeaway messages from PRIME and increasing from some of these other studies which Charlotte mentioned is that it's not enough to simply train primary care providers. We really are working with very constrained health systems, and we need substantive health system strengthening interventions to really make these realizable at a large scale. So we've decided to focus on these 6 health system pillars which WHO works with, and to try and take stock of where are we in relation to these, specifically for global mental health. So I'll be working through governance, financing, information systems, human resources, interventions, and service delivery, thinking particularly about quality of care, efficiency, and responsiveness. When it comes to governance, one of the big challenges that we face, especially with working with ministries of health in sub-Saharan Africa, in South Asia, and in Latin America, is that there's frequently limited capacity in the ministries of health to plan and to deliver services. We've seen a huge increase in the adoption of mental health policies in recent years, but the capacity to actually plan and deliver integrated mental health services is really severely constrained. Often people working in these positions are clinicians who've risen through the ranks, and they might be mental health specialists, for example, a mental health nurse or a psychiatrist or a psychologist, but don't have training in public health approaches, in mental health systems and health systems delivery. Or else they might be health practitioners without necessary training in mental health. So there's a huge gap in capacity and really a need for mentoring. And so in projects like the Emerald Project and the MH-LAP, which is the Mental Health Leadership and Advocacy Program led by Oya Gureje in Nigeria, we went about developing capacity building materials for planners, especially trying to involve service users more actively in the design of services. And we're really seeing that the next steps are around evaluating the involvement of service users, in evaluating capacity building for planners, integrating capacity building for planners and service user involvement into Ministry of Health systems, and potentially setting up virtual academies, virtual communities of practice among people leading mental health services in low and middle income countries. When it comes to financing, we've learned an enormous amount over the last 10 years or so, especially through the Emerald Project led by Graham Thornycroft and Prime. As part of Emerald, we did surveys in 6 countries comparing the household economic status of households who have a family member who has a mental, neurological, and substance use condition with households who do not have a family member with any of those conditions. And we found across the board, across a number of different poverty indicators, that households living with an MNS condition are significantly worse off. They have higher out-of-pocket payments, so a lot of work has gone into developing models to assess the population level impact of investing in mental health care, and Dan Chisholm has led a lot of this work. I'm sure many of you know his 2016 paper showing that for every $1 invested in care for depression and anxiety disorders, we would see a $3 to $5 return on investment over the 15 years of the Sustainable Development Goals. And so what we see happening next potentially is randomized control trials of economic interventions and different financing models. As countries move increasingly towards universal health coverage, we need to make sure that the financing models that are designed for funding mental health services in this integrated platform are done appropriately and are effective. So we need to be evaluating those and working with ministries of health. Just anecdotally, I've got a fantastic PhD student who worked in Emerald, Sumaya Dokrat, who is currently working on an investment case for the National Treasury in South Africa, and I think there are a number of countries working on developing these tools. What about information systems, this crucial part of the puzzle? We found in many countries that existing mental health management information systems are really not fit for purpose. And Mark Jordans and Oya Gureje did some wonderful work in the Emerald Project with a consensus study to try and identify key indicators which should be included, and ended up focusing on the domains of needs, service utilization, quality, and payments, and then subsequently tested these indicators in a feasibility study across all of the 6 Emerald countries. So this is really something where we see a huge gap, especially in low and middle income countries. We need to develop electronic medical records and ways of advocating for more routine collection of mental health data as part of routine health management information systems. Then when it comes to human resources, we found that task sharing approaches certainly can work and can lead to the kinds of improvements that I've mentioned. but it's really important that we involve specialists, that we don't see this as a one-off training event or as task dumping, but this is about strengthening health systems to provide ongoing support for non-specialist providers. We found, for example, through the Reshape trial, which was led by Brandon Court and Mark Jordans in Nepal, that introducing a stigma reduction component to the training of primary care workers can lead to significant reductions in stigma among primary care workers. And we did quite encouragingly, at least in Prime, find no evidence of increased burnout among primary care providers. Although I see there's one very interesting looking poster here which does report burnout, so this is something we need to keep being aware of. We think it's really important going forward that trials test different implementation strategies for human resources, and that we develop and evaluate non-technical skills, empathic listening, clinical communication skills. Then when it comes to interventions, we've seen a huge growth in randomized control trials evaluating task-sharing psychological interventions in low and middle-income countries. This is a wonderful systematic review and meta-analysis led by Daisy Singler with 27 randomized control trials, finding a pooled effect size of 0.49, which is really quite remarkable. Considering the challenging nature of the conditions and that these are all delivered by non-specialist health providers. However, there are important exceptions, and as you can see in the previous slide, there are a number of these trials in the forest plot which show non-significant outcomes. So actually, despite the pooled moderate effect size of 0.49, there is a lot of heterogeneity in there. And I just wanted to comment on a couple of exceptions to this trend. For the Affirm South Africa trial, we evaluated the delivery of a counseling intervention delivered by non-specialist community health workers in Khayelitsha, and found no significant difference between the intervention arm and enhanced usual care. This paper will hopefully be published in a couple of weeks, so this is kind of hot off the press. Also, Oye Gureje's Explanate trial, also with maternal depression in Nigeria, found no significant difference between a high-intensity and a low-intensity psychological intervention. So we need to be going into this a lot more, trying to unpack what are the mechanisms of some of these changes, how do we understand what didn't work, as well as what did work. And I think Daisy Singler has done a wonderful job of trying to unpack. This slide is a taxonomy of treatment components, really trying to look at what are the active ingredients of psychological interventions delivered by non-specialist health providers, and how do they lead to the kinds of changes that we observe. So this is an ongoing and very exciting and rapidly evolving field. Then when it comes to interventions or randomized controlled trials of community interventions, we found that active community case detection does increase coverage and improve outcomes in Nepal using the community informant detection tool, which Mark Jordans and colleagues led the development of. And then in the landmark COPSI trial, collaborative community care is modestly more effective than facility care alone for people living with schizophrenia, and this is work that was led by Sudipta Chatterjee and Vikram Patel and Graham Thornycroft. So really, we need to be developing this a lot further. There's a huge potential and really a danger that severe mental health conditions are neglected with a focus of much global mental health research on common mental disorders. And this is really of trials of interventions integrating mental health into primary care. And another hot off the press news, I think Charlotte just found out last night that there is a non-inferior outcome for delivering mental health care for severe mental illness in Ethiopia through primary health care compared to specialist care. This is work that's been ongoing since 2011. Gives you a sense of the time period that's involved, but that paper will be coming out hopefully in the next couple of months. So really a mixed picture. We're also waiting to hear the COSIMPO trial, which is Oye Gureje's trial, integrating primary healthcare and linking with traditional healers. Really incredibly novel cluster randomized controlled trial, randomizing villages to either set up collaborative care with traditional healers or business as usual. And I think that will be coming out soon with very encouraging results in the next couple of months. So I'm aware I'm a little bit out of time, and we wanted to leave 5 minutes for questions. I just wanted to mention the pivotal role of quality of care, and as our work in Prime evolved, in the final years of Prime, we really started to focus an enormous amount of energy on quality improvement and how do we integrate quality improvement. And this is something that really we're going to be taking forward in the work on asset, and has been taken up with the MINT and SMINT programs in South Africa. So what's really exciting about this field is that I think we are also reworking and constantly trying to redefine what we mean by integration. I think in the past we may have thought about integration as identifying people with a diagnosable disorder in a primary care clinic and delivering a service to that individual. In reality, people don't present in primary care clinics with full-blown diagnoses. They present with a complex range of signs and symptoms which require careful and respectful and humane care and support. And I think this is really exemplified in the PAC manual or PAC intervention package. PAC stands for Practical Approach to Care Kit, and it's been led by Lara Farrell and colleagues at the Knowledge Translation Unit at UCT. It's now in, I think, over 6 countries, really trying to adopt a fully integrated signs and symptoms approach. And this is also exemplified in the Where There Is No Psychiatrist book, now in its 2nd edition, written by Vikram Patel and Charlotte Hanlon. So looking to the future, this is a really exciting time to be working in this field. We now have a substantial amount of evidence to persuade governments to invest in mental health care through primary care and community settings. We need particularly to invest in strengthening health systems. And it's vitally important that we don't just focus on that facility level and training alone, but we strengthen health systems from the healthcare organization level, at the district and regional level, through the facilities, and crucially deliver services at the community level. In terms of research, we need to be investigating ways of strengthening health systems, testing psychological interventions in a more diverse range of challenging contexts, particularly focusing on children and adolescents, which is really a hugely neglected population, especially given the demographics in most of the countries in which we're working. And then linking primary health care with interventions to address the social determinants of mental health. Why treat people only to send them back to the conditions that made them sick in the first place? We really need to be partnering with a range of other SDG targets to link mental health with broader social and economic development. So thank you very much, and we'd really like to hear your questions. Thank you. I think there's one question over here. Do you want to come up, Sure.
Thank you very much for a very nice talk, and congratulations to everybody. I hear you say 2 things that seem to be pointing in 2 different directions that should not exclude each other, I think. On the one hand, when you emphasize the importance of health systems, it's indeed what we saw while the Emerald and Prime projects were ongoing, is that in the countries where they were going, there was a lot of pressure on the health systems to include almost any new idea that would come up, which they couldn't face. So I think that is a very important lesson learned. The other thing is, though, that when it comes to the health systems that are important, at the same time, what you also mentioned is that there is an enormous potential of people outside of any health system who could provide very useful services to increase mental health. And I think that relates to the call for action in the Lancet last week. Could you react to that, perhaps?
Yeah, so thank you for that. I really think it's not an either or. We need to do both and. You know, we need to strengthen health systems to improve delivery of care, but we also need to be addressing the social determinants. And I'm really excited about where we can go with this. We've got a grant application in at the moment, which is awaiting perhaps Brexit or whatever to get a decision from DFID. But our proposal there is to do a population-level mapping of the factors that drive adolescent mental health, and then to design at a district level a multi-sectoral response, which includes not just health facilities, but also schools, communities, digital interventions, ready to try and address some of these social drivers of mental health conditions. So I think that's the next exciting stage.
Aaron Poppleton from the Centre for Primary Care at the University of Manchester. A very interesting presentation. I guess my thoughts as a general practitioner is how actually, particularly I guess common mental health disorders, where there's huge overlap in terms of physical comorbidities that can go with this and the two feeding off each other, how a lot of the mental health interventions here can be integrated into, I guess, a broader concept of health, particularly within a primary care context where maybe there's not the same degree of medical training or capacity in that.
I mean, it cuts both ways. So people with common mental disorders, so people with physical health problems often developing common mental disorders, or as the pack indicated, sort of just distress or demoralization or some kind of just need for emotional support, even not at the case level. And then people with severe mental disorders who have undetected physical health problems and premature mortality, which is very much, there's a great potential by integrating in primary care that actually they may get better care, not just non-inferior care. They may get better care than if they're in a specialist service where their physical health is neglected, and if they're known to be in the psychiatric service and they're referred across, then the medics may not take them seriously. So I think, yeah, absolutely, there's a massive thing. And non-communicable diseases and chronic disorders are a particular focus, I think, going forward.
One more.
Any other questions? Just to say on that point, I mean, I think a lot of what's been happening in global mental health has also been piggybacking on other health priorities. So, there's a huge push and a huge amount of funding available for HIV, and a lot of the innovations around developing task-sharing models, for example, with the Friendship Bench, was working with people in a context of HIV. How do we deal with depression and anxiety in that context? So I think there has been quite a lot of work done. Okay.
Please. Yeah.